Dr. Elion, Dr. Krishnamurthy, Dr. Siddharth Das, dear delegates, distinguished delegates, good evening to all of you. Now, sickle cell disease in Odisha is the presentation which is to be given out by me, mainly highlighting on initiatives and the achievements that we have been able to accomplish since we started realizing that there is a problem in Odisha. In my talk earlier during the inaugural session, I had mentioned that there were a few sporadic cases that were actually being diagnosed in the state of Odisha, and that on a health, whether it is a public health issue or not, and should health managers be conscious of it, and should there be a policy and program for it, was not realized. I think till a long time after the first case was diagnosed in Odisha. This is very close to my heart also, because though I would not like to take credit for the entire thing that has happened, but incidentally, I was also there when we started realizing that this is an issue that needs our utmost attention, which was in 2009-10, when I was there as Mission Director, National Rural Health Mission. So this is the background. Everybody knows. I don't want to go through it again. And of course, these are technical issues. So again, I'll skip it. And of course, you have two types of issues under sickle cell disease and the trait. And the treatment, of course, line of treatment is different for both of them. And then obviously the clinical manifestations, acute manifestations, these are for the more for the technical side, people who are experts in it to understand, discuss and suggest to us, the health managers, how to go about addressing them. So in Odisha, the sickle cell is now, we are realizing it's a major health problem. So in fact, Odisha is one of the largest state with the largest number of sufferers from sickle cell disease and the trait. And this is mainly prevalent in the western parts of Odisha. Now we are realizing it is also there in the southern parts of Odisha. In fact, even during our discussions, some of my colleagues have told me that more and more number of cases they are also discovering from other districts like Koraput and Keonjhar and other tribal areas. But it is not only in tribal areas, it is also among certain castes where endogamy is custom, such as Agaria, Chasa and the Kulita. And obviously the marriages between the close relatives is an important issue there. Sometimes, and if you actually go to the field and meet the families, you'll sometimes find that the entire family except one or two are all are sufferers, and it's really a heart-rending situation, as Dr. Panda also mentioned, when you go and discuss with them their issues. So realizing all this, there was one man, obviously there was a team, but I'm mentioning him because he was so passionate about doing it, to take it into the public health program, to institutionalize the entire mechanism of screening, the treatments and the follow-ups at each level, whichever is possible during those times. Professor Patel, you can see him just right behind the Chief Minister, and on the right side, to my right, perhaps to your left, is the Health Minister, the then Health Minister Prasanna Acharya. Incidentally, Professor Patel is from Western Odisha. Prasanna Acharya, Mr. Prasanna Acharya was also from Western Odisha, and perhaps they realized the sensitivity of the issue. And since I was there also, as a doctor who actually really understood a little bit about sickle cell disease, not an expert, we thought that there is a problem and that we need to start a project there itself. So we sanctioned it in April 2010 under Odisha Health Sector Plan, not under National Health Mission, because perhaps it was still to be realized there. So we started it with the help of DFID, UK, and then what we did was to have an infrastructure available there with the human resource which is required, which will then ensure screening and confirmation of all the sickle cell sufferers with the disease as well as the trait. And we wanted that there should be a free consultation for all, because these are poor. It's also a social issue. It's an equity issue, as somebody also mentioned earlier. It's an equity issue where the patients are generally from the poor and the weaker and the marginalized sections of the society, the tribes and the caste there. So we wanted a free consultation and treatment, and much more important, as is being realized throughout the discussions in the Congress, generating a robust database so that we follow up. We follow up with their families, we consult, we give them, consult them on what is happening. We also provide free consultations, and we also can, with the help of the data, promote further research by following up with the sufferers. Then for that required that we need to have a nodal center. The nodal center was started in the Medical College Bulla, and we also started with just 6 districts initially around Bulla, in the periphery of Bulla, as the peripheral units, the district sickle cell units. So in the first phase, we started with just 6 districts, and then in the second phase, another 6 districts were added. These are the districts in the first phase on the green and yellow type, and those with marked with pink are taken later on. But we intend to expand it further as the evidence is generated on those districts also. This was funded, as I said, OHSP and NHM, and then obviously at that same time initially we started just with an OPD clinic and the medicine ward there, and we realized that we need to have a separate institute for it, sickle cell institute, which needed to have its own infrastructure, which was then created, and the Honorable Chief Minister later on, who actually laid down the foundation of the project, also later on inaugurated the institute building during his time on 27th February 2015. This is the Sickle Cell Institute in Bulla now, and these are those aims and objectives which I earlier mentioned. All have been fulfilled, are being fulfilled. We screen, we confirm and register, we counsel, we treat, we follow up, and we refer them to higher centers. We provide free hydroxyurea, which is a very costly treatment, and we also have health camps and field visits. Now we have also integrated it with the RBSK, which is Rashtriya Bal Swasthya Karyakram under NHM, which Dr. Arun Panda also mentioned. Then we are also conducting CMEs, the continuing medical educations and conferences on this, like this one. And the research, publication, and collaborations are also part of it. These are some of the photographs of what I just mentioned: registrations, examinations, drug distribution, sickle cell patients. And so we do a basic test now, slide test. Why I'm mentioning this is because this is actually sometimes comes in the way of which Dr. Arun Panda also mentioned. We need to now come out with some innovations on screening in the community, because point of care is an issue now. Many patients now have to travel. Earlier, not realizing that this was a health issue, but an ethical issue. Obviously, people didn't realize that the problem is there. Patients would generally come only up to CHCs or DHS and go back. But now realizing that there is a center which provides all the tests and the free drugs which are given to the patient, they have to travel long distances from remote areas. Transportation itself is an issue. So point of care is very important in communities, and if we can do it at the school level itself, but the innovations on the screening are lacking. There are some good signs I have heard, but not they do not have 100% proven technologies. That is something that we need to do for mass screening. And then registration, counseling, and referral is what we are now doing at district units and health camps and field visits. Just before 1998 to 31st March 2010, the data that we have, In 12 years, we had the attendance of the patients was just 14,749 from 1998 to 2010, almost 12 years. And just after implementation, it shot up to 1,38,071, which means there was a hidden need for the project, which was clearly proven by this data. And the number of registered sickle cell disease, out of that 1,30,077, we have 13,886 patients who are registered with sickle cell disease, the SCD, and with the SCT, 16,027. And it has been increasing from year to year, year on year. These are the equipments, high-end equipments, which we have at the Center of Excellence and at the district level. And this is what we have done at the district units also. 72,660 persons have been screened, of which 14,745 are trait, and these 4,255 are suffering from sickle cell disease. These are the number of health camps that we have done. They have increased over the years, and more health camps are being conducted every year. This year, we now need to go further. We have a micro plan for screening all the school children, which we have just started under RBSK, and now almost 40 camps per district is our target in 12 project districts. And these are some of the sickle cell health camps that we have organized over the years. Field visits also to the families, counseling them, and conferences and CMEs. Professor Sargent can also be seen here. He had visited Bulla. He, in fact, has stayed there for 6 months, I am told, and has done a lot of research there. And these are the CMEs that we have held. These are the doctors which we have trained. Training is very, very important, crucial, so that research is done, so that knowledge is carried on from generation to generation. And obviously of the paramedical side also. 12 program associates, field workers, and LTs were also trained. These are the ANMs also of the resident. In fact, in Odisha, we have a unique example of the Sevashrams, the ashram schools, which are residential STSC schools, where we have actually provided one ANM per residential school who stays there in all the, and provides the basic treatment, first aid treatment and other treatments, and also takes care of taking them to the hospitals whenever it is required. Research and publication, we have done a lot on that side. We have also, I mentioned earlier also, a lot of very important and reputed journals have, there we have our publications published on hemoglobin, on International Journal of Tropical Disease also, on clinical spectrum of severe plasmodium, falciparum malaria, and these were all related with sickle cell disease. So effect of hydroxyurea. So all these have been done by our doctors in these facilities over the years. And now the Odisha Sickle Cell Project with the support of NHM and the Anthropological Survey of India also have undertaken a collaboration project on genetic study of inherited hemoglobin disorders in Western Odisha under the same Odisha Sickle Cell Project funded by NHM. This will obviously give special emphasis on sickle cell disorders and will enrich us further and to take up research further on the genetic aspects of genotype-phenotype correlations by doing DNA sequencings. And the way forward, obviously, I mentioned in my presentation also at some point, neonatal screening now is becoming very, very important. Antenatal screening, early diagnosis of SCD is giving choices to the parents to ensure whether they would like to carry on with the pregnancy. And also it will allow us successful interventions like prophylactic penicillin and pneumococcus vaccination also if required. Prenatal diagnosis I mentioned, and screening, upscaling, that which I mentioned earlier, upscaling a project with very cost-effective, innovative technologies is the need of the hour, and we would like actually to the Congress to throw up ideas which can actually be implemented in the field. Thank you so much.